Hey team, this presentation is a quick review of nursing responsibilities and documentation requirements during a stroke protocol and TNK administration. NEA is currently certified as a primary stroke center by Joint Commission. This is based on a review of compliance with national standards, clinical guidelines, and outcomes of care. We also follow the Get With the Guidelines and have a gold recognition for achievement measures. There are some of the measures we follow to remain certified. I have highlighted the measures required by nursing that pertains to ED. We also have a door-to-needle time of less than 45 minutes and a door-in, door-out time of less than 90 minutes. Here are our stroke order sets. The pre-CT and post-CT can only be initiated by a physician. If we enter those in, they have to be ordered verbal with readback. However, our stroke greater than 24 hours from last well time is a standing order and is nurse-driven. When triaging, if a patient exhibits signs and symptoms of a stroke, using the B-FAST mnemonic, including dizziness, unexplained syncope, and altered mental status, with the last known well time that is less than 24 hours ago, then we ask for a physician's evaluation. Once the physician evaluates, if we receive a verbal order to initiate our stroke protocol, we order the pre-CT order set. We ask registration to page it overhead, and here is what the order set looks like in Epic. You head on over to orders, you type pre-CT, and it says EM for emergency. It includes your glucose, your labs, a COVID test, EKG, X-ray, your CT, which is a hard stop and it asks for the reason for exam. We're going to say dizziness. Also ask your doc if they want a CTA when they tell you they want to go ahead and call the stroke protocol. So the CTA is here. You also have to put the signs and symptoms that they're having. This consult to teleneuro is another hard stop. Our callback number is going to be the physician's desk. It's 870-936-1137. Our person of contact is going to be the ordering physician, so we're going to say it's Dr. Bags. And the cart number in ED is 2. All right, and hit sign. Remember, this is not a standing order. This is a verbal with readback order only. It's not a per protocol. It is verbal with readbacks always for any of these order sets. Once the orders are in, we can take the patient to CT. Our goal to initiate a CT is less than 15 minutes. The ED code nurse takes the red stretcher to CT and returns the patient to the ED room where the teleneuro consult takes place. During this time, the ED code nurse is attaching the patient to continuous monitoring, including leads, pulse ox and blood pressure cuffs, starting 2 IVs, obtaining labs, and a bedside glucose. The primary nurse is responsible for documentation in the stroke navigator during this time. Examples of what the primary nurse should be documenting include what time the patient is back in the room, what time the patient is in front of the neurologist, and verifying vital signs. The primary nurse is responsible for making sure these 4 things are documented. You can easily see what has been documented in the stroke narrator. So we're going to head on over to the stroke narrator. Most of the time, it's going to be in the top. Sometimes you'll have to head on over to this drop-down box. It might be in rarely used, but you will be able to find it somewhere over here. So we're going to go to the stroke narrator. I normally get rid of the quick bar vital signs and validate my vital signs through here. You're going to start your stroke documentation as soon as you get into the narrator and go to our last known well. This is what I'm talking about, where we as a primary nurse needs to be documenting the last known well. This patient specifically was 1220. This ensures a seamless communication and chart instruction for later in the hospital stay if our primary nurses are documenting the last known well here. A few things about a swallow screen to remember. We must have this documented prior to giving anything PO, and it can only be done once. The first line, patient with normal speech and swallowing prior to arrival, means that at baseline, the patient has normal speech and swallowing. We should be reporting if they pass or fail their swallow screen when we call report upstairs, and make sure you fill in the last box with the result of your screen. This is what it looks like. We're going to say yes, 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 yes. They don't have clear speech. We stop there. We have to fail in this box, and we have to hit this last button, fail, in order for it to count. these three fails. Okay, accept and get a green check mark. Pass or fail, we should be ordering an SLP eval. So this is what that looks like. Once we fail, we're going to type SLP, enter. It's SLP eval and treat, and the priority is for stroke. It is yes, a barium swallow, and they can change the diet as needed, accept, sign. This is per protocol. So I would order this per protocol under the ER doc, accept. That's been completed. Here is a process Casey wrote that works well. If you would like to review it, I have more copies if you want some. So she has that you need at least 2 nurses in the room. This is going to be your ED code nurse and your primary nurse, especially whenever the patient is in the 4.5-hour window. We need to make sure we get an accurate weight. If we are giving TNK, we're going to enter the post-CT order set. This is for TNK or a hemorrhagic stroke. It includes all meds for hypertension, and this is what it looks like. We're going to hit post-CT. It's for ischemic stroke with the thrombolytic. Yes, we know the last known low. We're going to confirm. You have to select your thrombolytic twice. This is a hard stop. We're going to say Q shift for a neurocheck. Another hard stop for ischemic stroke education. We're going to say daily. And here are your antihypertensive meds. You want to ask your ER doc which ones they would like. If they want Cardine, you ask them what they want the systolic blood pressure to stay under. And that's all the hard stops. And that's really all that you need. This is always a verbal with readback order. It's best if the ER doc puts this order in themselves, but that doesn't always happen. So if you need to put it in, it's a verbal with readback under the ER physician. Once you have that order in, you can see all of your meds. These are PRN in case your systolic is greater than 180. And here's your TNK order. Now, to give TNK, we have to have an accurate weight because it's weight-based. If we are nearing the end of the 4.5-hour window and we want to pull TNK from the Omni prior to the order being put in, we can override, but in order to do that, you must type tenecteplase or tenect, T-E-N-E-C-T. If you type TNK, it won't show up. This TNK tool is located on the teleneuro cart for reference. We need an NIH documented on presentation to ED and immediately prior to TNK. Now the patient's 1-to-1, which means the nurse is in the patient's room performing an NIH and verifying a full set of vitals every 15 minutes, with the exception of temperature that's every 4 hours until they're transferred to another facility. The timing of required documentation after giving TNK in Epic is super confusing and the times are not accurate, so use the paper tool to make it easier. One stroke measure we rarely hit is a door-in, door-out time of less than 90 minutes. We need to initiate the transfer as soon as we know that we are giving TNK. The teleneurologist will sometimes do this for us, so ask them while they are still on the screen if they will. If they don't, all you have to do is call the patient placement center to initiate. They are on speed dial at the blue nursing station, or you can call this number and hit option 1 for emergent transfer. All they need is name, date of birth, maybe MRN, and reason for transfer to initiate that transfer request. If there is delay in transfer of any kind in this process, document the reason in a nursing note in the context of reason for delay for chart abstractors. This excludes the patient from that measure and prevents fallouts. For example, there is a delay in transfer due to family deliberation about whether they want to be transferred, or there is a delay in transfer due to EMS availability, or there was a delay in TNK administration due to the systolic blood pressure being greater than 180. Thank you for listening. If you have any questions, here's my contact information. Feel free to stop by my office anytime and don't hesitate to reach out. Thank you.